Hello, and welcome to the CAP Today webinar for Wednesday, September the 15th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentations. Today's webinar is entitled CSF Biomarkers, Aid in the Differential Diagnosis of Alzheimer's Disease. This webinar today is made possible by a special educational grant from Fuji-Rabio, and we want to acknowledge them and thank them because they've done a lot to support this very important session, so we're very grateful. Our speakers today, and I'll say more about them in due course, are Dr. Alicia Algeciras-Schimnich of the Mayo Clinic, Dr. William Hu of the Rutgers Robert Wood Johnson Medical School and Institute for Health in New Jersey. And lastly, our third speaker, Dr. Leslie Shaw of the University of Pennsylvania in the Perelman School of Medicine. He's a full professor of laboratory medicine. But before we begin, I want to share some housekeeping tips that I think will enhance your enjoyment of today's webinar. We often suggest that you refresh your browser for the ultimate syncing of sound and slides. There is in the bottom right-hand corner of your screen a toll-free number with live operators waiting to assist you should you have any technical problem. Call 888-364-8804. Also, you'll see below the slides a box labeled Q&A. In that box, you can type in technical concerns or issues, again, with the website or the audio or anything else, and we have live people who can assist you with those questions. But of course, the Q&A box is principally there for your comments and questions for our speakers on the program today. And as I mentioned, after our formal presentation, I will moderate a question and answer session based on what you have asked. The full slides and audio of this presentation will be available to you for review at captodayonline.com in about a week. And they'll stay up for about a year on captodayonline.com, and I'm sure you can also get this through Fuji-Rabio. You'll see some follow-up email, and I want to alert you to that. And finally, I do want to note that CAP Today does not endorse any product or service that may be mentioned in today's webinar. Any remarks that I make are purely my own personal remarks and not to be taken as policy of the CAP Today or the College of American Pathologists. And now with that, we can begin. And I'm going to introduce our first speaker. And that's Dr. William Hu. He's an MD and a PhD. He's a fellow of the American Academy of Neurology, and he's associate professor and chair of cognitive neurology at the Rutgers-RWJ Medical School, also at the Institute for Health, Healthcare Policy, and Aging Research at the Rutgers Biomedical and Health Sciences Center in New Brunswick, New Jersey. It's a great pleasure to have him as our first speaker, and he'll begin with an overview of Alzheimer's disease. Dr. Hu.
Thank you, Bob, and I want to welcome everyone again to today's webinar, and I think this is something that all the panelists feel very passionate about, so we'll try to stay on time and answer whatever questions that come up. First, I want to just tell you a little bit about Alzheimer's disease. It is certainly a growing health concern in the United States and elsewhere. It is estimated in the U.S. that about 1 in 10 people over the age of 65 have the disease, and so that would make about 6 million Americans overall living with Alzheimer's disease. This is not an equal opportunity disease as it impacts women more than men, and it is more common in Blacks and Hispanics than in whites. This is an age-related disease, so that the prevalence of disease increases as one ages, and depending on the study, it is anywhere from the third leading cause of death to the sixth leading cause of death in the United States. What's important I want to also bring to your attention is this pie chart on the right even though we think of Alzheimer's disease risk being the greatest in the oldest of the older group, in the 85 and over, because of our population structure, currently about half the people actually fall into the decade below that, from 75 to 84. And the little slice of pie for the under 74 likely increase dramatically over the next 10 years because the baby boomers entering that age range. When we talk about Alzheimer's disease, most people think of Alzheimer's dementia or Alzheimer's disease dementia. It can be roughly divided into 3 clinical stages of mild, moderate, and severe, depending on how much function is impaired and how much assistance someone needs. However, just like people do not suddenly wake up one day with moderate Alzheimer's disease and they go through a mild stage before then, people also don't suddenly wake up one day with mild Alzheimer's disease. It's being increasingly recognized that people go through a number of phases before even dementia sets in. And here we define dementia as having enough cognitive impairment to interfere with function and independence. Before mild dementia, there's a phase where often people wonder whether this is just normal aging versus the earliest something more sinister that we call mild cognitive impairment. And if it's due to Alzheimer's disease, we add a qualifier, mild cognitive impairment or MCI due to Alzheimer's disease. But even before any symptoms begin, just like carcinoma in situ or atherosclerosis before heart disease, we know the Alzheimer's disease pathology can emerge. And increasingly, researchers and clinicians are recognizing a phase of what's called pre-symptomatic or preclinical Alzheimer's disease as we look at the entire disease continuum. The cause of Alzheimer's disease remains debated, but I think the core pathologic features of Alzheimer's disease have led us to a number of putative theories about what causes Alzheimer's disease. The 2 main pathologic changes in Alzheimer's disease include the neuritic plaques and the neurofibrillary tangles. The neuritic plaques are composed of the highly aggregatable beta amyloid 1-42 protein or A-beta 42 protein, whereas the neurofibrillary tangles consist of hyperphosphorylated tau pathology. And it is a combination of these 2 pathologic changes plus others, including neuroinflammation, neurodegeneration, that lead to the clinical manifestation of cognitive impairment and dementia. And the diagnosis of Alzheimer's disease up until recently has remained largely clinical, short of the gold standard of autopsy after someone has passed away. As the older guidelines, such as the one from 1984, proposed a functional definition in that if somebody has sufficient functional impairment to lead to dementia in an old age, and without another alternate explanation, such as low thyroid or vitamin B12 deficiency, then there is diagnosis of probable or possible Alzheimer's disease can be made. Because of the recognition of milder stages, such as mild cognitive impairment, as well as advances in biomarkers, which we are talking about today, a new set of criteria were formulated by the National Institute on Aging and the Alzheimer's Association in 2011, which recognized not only these pre-dementia stages of Alzheimer's disease, but also the utility of biomarkers. And then finally, parallel to the development of some of these diagnostic guidelines, DSM-4, which often the psychiatrists rely on, have also been modified over time to reflect the advances in understanding clinical disease. Again, one of the goals of clinical diagnosis is to predict what the underlying pathology is. As I mentioned earlier, the core pathology of Alzheimer's disease includes neuritic plaque consisting of A-beta and neurofibrillary tangles consisting of tau. So in addition to the clinical staging as discussed previously, there's now a research framework which we hopefully will advance to the clinical stage, where we define various levels of cognitive impairment according to the presence or absence of these key Alzheimer's pathologies. And this is commonly known as the ATN system, where the A stands for amyloid beta pathology, T stands for the tau tango pathology, and N stands for neurodegeneration as a result of the core pathologic changes. And depending on the combination of whether each biomarker is present or absent, a number of conclusions can potentially be drawn. And those conditions where amyloid beta pathology or A pathology is positive is considered to fall along the Alzheimer's disease spectrum, as demonstrated on the right side here. So the key thing, and very often nowadays in clinical diagnosis, goes beyond confirming the presence of cognitive impairment, but also the confirmation in some way of amyloid pathology and ideally tau pathology, as well as neurodegeneration. The reason this is important is that Alzheimer's disease is not only cause of dementia, and diagnostic accuracy varies depending on the setting, the clinician, and the case presentation. Other than Alzheimer's disease, there are a number of other dementias or neurodegenerative diseases that can present very similarly, including Lewy body dementia, frontotemporal dementia, and so forth. Without biomarkers, we often rely on clinical features, on MRI patterns and atrophy, which are suboptimal in clinical pathologic series to predict underlying pathology. And with that, I want to move on to the next section and give a brief introduction on ways to predict the amyloid pathology as I've discussed earlier. Currently, amyloid PET imaging is the only FDA-cleared method to identify the presence of amyloid pathology in the brain short of autopsy. And this is validated against autopsy in this in this tour de force study. Investigators performed amyloid imaging in people near death, both with and without clinical Alzheimer's disease. Then the participants agreed to donate their brains afterwards so that the PET imaging results can be validated against pathologic analysis. And the amyloid PET findings were found to be highly correlated with a postmortem amyloid immunohistochemistry, and then therefore this became a relatively reliable way of detecting amyloid ante-mortem. The amyloid imaging agents, now there are 3, as you'll see on the next slide. They generally bind to the insoluble fibrillar form of an amyloid deposit, the A-beta deposits, and they can their quantitation, the quantitative analysis of A-beta ligand retention in the brain, and can potentially provide diagnostic as well as prognostic information about the person's cognitive impairment. As I mentioned, there are currently 3 FDA-approved amyloid tracers that are available for PET diagnosis, and there's 1 FDA-approved tau tracer that's currently approved. And what's interesting is that while these are readily available in research settings, the broader applicability of these agents is being debated. And that's because of some general limitations of PET imaging as well as specific limitations related to amyloid PET and likely tau PET. So what am I talking about? In terms of general limitation of PET imaging, you need a PET scanner, which is not readily available at all, even medium-sized cities. Certainly, I think it's highly straightforward to get a PET scan in Boston or San Francisco, but that's not the case in many other major cities, and then not remotely the case in more rural areas. It requires a nuclear medicine expertise to interpret the study. Like any other type of imaging study, the experience is related to volume. So if you don't do the imaging frequently, the injection of the tracer as well as the interpretation of the retention may be variable. Specifically about amyloid PET and likely tau PET, it only detects one protein because it's a single tracer that emits a single wavelength. It's a positive or negative test. So if you're detecting two types of pathology, such as in Alzheimer's disease for amyloid and tau, you essentially need two PET scans. And importantly, these scans are costly because of the need for a cyclotron to generate the radiolabeled light tracer, because of the expertise needed for a nuclear medicine physician. These can create a financial burden both on the healthcare system as well as the patients. And with that, I will hand back over to Bob.
Dr. Hu, thank you very much for that great overview and very interesting detail on the PET imaging, and lots of interesting facts and limitations for us to consider there. I do want to remind the audience that they can ask questions or make comments at any time simply by typing into the Q&A box that you see there below the slides. Our thanks again to Dr. Hu, and he will be around for questions and answers later on. Now it's my great pleasure to introduce our second speaker. Dr. Leslie Shaw is Professor of Pathology and Laboratory Medicine at the Hospital of the University of Pennsylvania. He's the Director of the Clinical Toxicology Laboratory, all, of course, at the University of Pennsylvania Perelman School of Medicine in Philadelphia. It's also important that you know that he directs the biomarker core for the ADNI study, which is extremely important in this context, and I'm sure he'd be happy to answer questions about that later on. But for now, let me introduce Dr. Shaw, and he can begin his presentation. Dr. Shaw.
Thanks, Bob, and good afternoon, everyone, or good evening, depending upon where you are. And I'm looking forward to these discussions very much. Could I have the next slide, please? Thank you. So, as Dr. Hu had indicated, over the past years, there's been a transition in how Alzheimer's disease is detected in a living patient. We've moved from pure clinical diagnosis, which still is a mainstay, to more and more use of biomarkers, imaging biomarkers, and for us, CSF biomarkers, and down the road, blood-based biomarkers. So the fact is that roughly 20% or even more of people who were diagnosed as having Alzheimer's disease actually did not have it and were misdiagnosed. In the expert centers, about 20% rate of misdiagnosis, but even greater in less expert settings. Next. So now we turn our attention to what is it that we can measure in CSF. We can measure two classes of biomarkers very readily now. One that reflects amyloid pathology, and that is A-beta 42, and a near neighbor of A-beta 42, A-beta 40, total tau, and phosphorylated tau. So these biomarkers, in terms of the levels themselves, increased plaque burden is reflected by lower and lower CSF A-beta 42 levels, and increased neurofibrillary tangle pathology reflected by increased levels of tau or p-tau. These tests have been validated widely against autopsy, and even more so recently against amyloid PET imaging and to some extent tau PET imaging. So these core biomarkers that we're testing then are very valuable for early detection of this disease, and especially important in helping in differential diagnosis. Next. So amongst the advantages of CSF biomarker testing as compared to PET is in one sample we can measure these 4 or even more than 4 biomarkers that we just noted. So one sample providing for 4 measures. The cost is considerably lower as compared to amyloid PET, and of course the limited availability of amyloid PET, as Dr. Hu had noted. And so based on all the data to date, there's a very good, very high sensitivity and specificity of these tests to reflect in the living person the pathology in that individual. So in other words, these tests serve as a surrogate for autopsy. That's now pretty much an accepted principle in our field. Next. Some finer points with respect to these measurements. It turns out that for A beta 42, we can actually improve upon A beta 42 alone as an indicator of AD pathology because of some variation in 42 that is correctable by ratioing it to A beta 40 for technical reasons and also to compensate for changes in metabolism, comparing low metabolizers versus high metabolizers to kind of normalize those variations or variables by ratioing 42 to the much higher concentration and much more stable concentration of A beta 40. It's also true that we can ratio A beta 42 to tau or tau to A beta. Either way, that ratio also improves the ability to reliably detect, for example, amyloid PET plaque-based burden measurements. So the NIA-AA guidelines are now complete with defining and incorporating these biomarkers, and the ATN scheme that Dr. Hu mentioned has been very useful to help us further delineate what is going on in an individual patient as far as risk for developing dementia. Next. So a formal review of CSF testing was done and reported in 2018, comprising a group of neurology physicians highly experienced in dementia diagnosis, as well as some laboratorians and ethicists. And this group developed criteria for CSF testing. What you see here is a listing of the 6 indications for which it was felt that this testing is useful, it is valuable, and objectively has been proven to be of benefit. There are also a number of circumstances where it's not necessarily an indication, and all of that is reviewed in that 2018 paper. So the next. So now, quickly turning attention to a little bit more discussion of the benefits of CSF testing. Next. Next. Thank you. So in terms of the world's literature and the studies, of which there are a fair number now, it is pretty clear that there's high sensitivity and as well as specificity for detecting amyloid plaque burden and tau pathology in the living patient. So, for example, when we look at folks with mild cognitive impairment, for example, the sensitivity and specificities that you can see in the top 2 rows using PET and or autopsy diagnosis with ROCs of 0.93-ish for A beta 42 alone, and then for the ratio, it moves up a little bit higher on average in the world's literature. As well as that is comparing the 42-40 ratio to tau or tau to 42 ratio, as some describe it, where we see a little bit of an improvement in the overall sensitivity and specificity and ROC curves. In our experience, the p-tau 42 ratio is maybe 2 points higher in AUC or 3 points higher in AUC compared to 42-40, and those are about 0.4 to 0.5 points higher in ROC. Next. And then when we examine this in folks who are cognitively normal, but do have a certain degree of plaque and tangle pathology in their brains before any clinical signs whatsoever. And this is just showing us that similar degrees of diagnostic accuracy for detecting AD, those two parts of the AD pathology, amyloid plaque burden and tau tangle burden reflected by those tests, pretty comparable to what we saw in NCI domain. The next. Thank you. And so it is also recognized that one of the values of these tests is differential diagnosis of AD versus other causes, other neurodegenerative disease causes, for example, of dementia. And so that observation has been convincingly shown across many studies. And so diagnostic accuracy then in difficult clinical circumstances that are listed here for your review is very well documented, and keeping in mind that the diagnosis accuracy is limited. I think that's the last. Is that the last one? Okay, quickly, how do we even know that these tests are valuable? That has been formally evaluated, and here we see a summary of several different studies covering more than 1,800 individuals and comparing the question of across no dementia, MCI, and AD, and other dementias. Did the test result impact your decision making? Did it increase your confidence in your clinical judgment? And clearly, the answer is yes across all of these. This is still a topic of more widespread evaluations in other settings, but so far the data is compellingly supportive of the value. Next. And so amongst the values then of this kind of testing is identify folks for treatment with currently available meds, and especially for ongoing or up-and-coming clinical trials. Really important for objectively knowing, is the person I think has Alzheimer's, do they really have it? We don't want to put someone in a trial if they don't have Alzheimer's as the cause of their symptomatology. So here's a very strong indication for the value of these kinds of tests. And we expect to see a lot more studies incorporating CSF and in the future plasma biomarkers to help determine the role of these biomarkers not only in entry into clinical trials, but also to monitor for drug effects. So one effect of a drug that's treating against amyloid plaque burden is if it's effective, we expect to see less tau pathology. So we'd be measuring those biomarkers in CSF for that purpose. Next. Thank you. And now turn this over to Bob. Thank you very much.
Yes. Dr. Shah, thank you very much for a very, very compelling overview of these four core biomarkers and their importance. Clearly, they're going to become major players across the scene in this difficult world of Alzheimer's disease. So thank you very much for that. And once again, Dr. Shah will be around for the question and answer session, so feel free to make comments or ask questions. And finally, now we come to our third speaker. Alicia Algeciras-Schimnich is a doctoral scientist. She's a professor of laboratory medicine and pathology in the Department of Laboratory Medicine and Pathology at the Mayo Clinic in Rochester, Minnesota. Dr. Algeciras, please begin.
Thank you, Bob, and thank you, everyone. I think Dr. Huan and Dr. Shaw has done an excellent job showing you the value and the benefits of CSF biomarkers. So I want to spend a little bit of time talking to you about some of the obstacles that we see both from the clinical and the laboratory perspective in implementing these biomarkers. So when we look at the collection of a CSF sample, one of the perceived issue is the need for a lumbar puncture, which is a procedure that has negative perception for potential complications such as post-LP headache. In patients, too, this procedure is perceived as a frightening invasive procedure, which will significantly increase the risk of self-reported discomfort and complications. However, when you look at the literature, it's actually been documented, very well documented in a large number of patients and a large number of studies, that the CSF can really be collected safely and reliably via LP. And the most reported complication is short duration mild headaches that is observed in about 5% of, or less than 5% of subjects. Now, in order to avoid post-LP complication, it is recommended that an atraumatic narrow bore needle is used, and this is associated with less risk of post-LP headaches. It is also recommended to avoid repeated attempts in difficult LP cases, and this also will reduce the risk of lower back pain. And finally, to not collect more than 30 mL of CSF in order to, which is the recommended threshold to avoid post-LP complications. Now, when we look at the pre-analytical phase, one of the most critical pieces of this phase is the collection of the sample in the correct tube type. And it is the issue with A-beta-42. This is particularly important for A-beta-42 because this is a very hydrophobic peptide that tend to be absorbed into the walls of the tube. So collection of tubes that are sample collection in any tube that is not a polypropylene tube will result in absorption of A-beta-42 into the tube and can falsely result in low A-beta-42 concentrations. As my colleagues mentioned early on, a low A-beta-42 level is pathognomonic with AD pathology, so you can imagine that collection on the wrong tube type may lead to misdiagnosis of these patients. As newer assays are being introduced, manufacturers are introducing recommendations and standardization of the collection, the CSF collection tube, and the current recommendation is for the use of polypropylene low bind tubes. In addition to the tube type, the volume of CSF that is added into the tube, as well as the number of transfers of CSF into various tubes will have an influence in A-beta-42 levels. So a low CSF volume in respect to tube surface area can result in low A-beta-42 concentrations. And while the recommendations may vary by the manufacturer, it is suggested that at least 50% of the tube is filled with CSF. So if you're using a 2 ml tube for collection, then you should at least have 1 ml of sample of CSF in that tube. And also, the more you transfer your CSF from tube to tube, you will have an increased decrease of A-beta-42 with about a 5% decrease of A-beta-42 with each transfer. Now, recently, the Alzheimer Association published a guideline for the handling of CSF for routine clinical measurements for both amyloid beta and tau, and it provides recommendations for the sample handling, measurement, storage, and both fresh and frozen CSF samples. In this figure just showing you the recommendations for fresh sample handling. Starting with the lumbar puncture procedure, this should be once performed. You should remove the first 2 mL of CSF and then collect your sample for AD biomarkers after those 2 mL. It is recommended that the CSF is collected by the drip method, and that is collected directly into the low-bind tubes that I mentioned earlier. Once the sample is collected, the nice thing is that no further handling should be necessarily unless the sample is hemolyzed, which at this time it is recommended that the sample is centrifuged. But then the sample should be sent to the laboratory, and it should be either kept refrigerated for up to 14 days or at room temperature for up to 2 days. And testing at the laboratory will not require any additional handling or transfer of that sample. The sample should be really tested directly into that using the collection tube. And ideally will be measured on a system that have high precision. Now, one of the challenges that we have faced for the introduction of the CSF biomarker into clinical use has been the lack of universal cutoff, and that's really been related to a number of variables that include analytical variables that of prior available assays, including differences in results between different lots of reagents, differences between methods, and the lack of reference material to standardize the measurement of these analytes. And as you can see on this figure, this is looking at a beta 42 imprecision, or the coefficient of variation for interassay, looking at an automated chemiluminescent assay on the green, and then 2 automated two manual assays. So the first one being an automated assay, the next 2, the Luminex and ELISA, being more manual, labor-intensive assays. And you can see clearly that the use of an automated assay reduces the variability that is observed in the results, and that is true across the range of concentrations tested. Now, I want to spend a little bit of time talking to you about the evolution of biomarker testing, because there has been so much exciting progress being done in the last few years that I think is bringing us closer to the routine clinical use and the root of these biomarkers, and us being able to provide these in the laboratories. So when you look at the evolution, historically, a lot of the research work has been done using manual ELISA assays. And in recent years, the introduction of 2 fully automated immunoassays have allowed for a decreased intra and inter-lab variability of the measurements. So today, we have 2 automated platforms available to measure these biomarkers. We have the Alexis platform from Roche Diagnostics, and they offer a beta 42, p-tau, as well as total tau. And then we have the Lumipulse platform from Fuji Revio Diagnostics, who offers a beta 42, a beta 40, p-tau, as well as total tau. And all of these assays have been really shown to have greater than 90% concordance with amyloid PET classification. So really are very well positioned to replace the manual immunoassays and help clinicians in this differential diagnosis of Alzheimer's disease. There is significant effort also being made to ensure standardization of these assays. Another key step forward or towards the clinical implementation. And this timeline showed some of the accomplishments in recent years. As was mentioned earlier, the ATNI program was launched in 2004, and this is a multi-center study that looks at the brain changes in patients that are cognitive normal, patients with mild cognitive impairment, and patients with early AD dementia, and looking at a number of biomarkers that are well standardized throughout the course of the disease or changes in the brain status of these patients. In 2009, the Alzheimer's disease sponsored the implementation of an international quality control program that is available today for CSF as well as plasma biomarkers. And any laboratory or any manufacturer is able to participate in this program, and input is provided both in the longitudinal performance of the biomarkers in your institution over time and information about how the different methods compare. The implementation of the reference material for A-beta-42 has been very critical, and both of the automated assays are going to be standardized against A-beta-42, and measurements should be very comparable between these two systems. And as we mentioned, or as I mentioned earlier, the most recent effort for standardization has been related to the protocol for CSF collection and handling. Now, looking into the future, there is great hope for the introduction of AD biomarkers in blood as a means to have a less invasive way for sample collection. One of the challenges is that the AD biomarkers concentrations in blood are significantly lower than in CSF, so the assays we're using today for CSF cannot be used to measure AD biomarkers in blood. However, there is a number of promising work looking at A-beta-42 or A-beta-40, showing that it correlates very well with both CSF and amyloid PET. One of the potential issues with this A-beta-42, A-beta-40 ratio is that the changes in AD patients in plasma seem to be modest, and they might not be able to discriminate as well depending on the assay that is being used, whether it's a mass spec or an immunoassay. Another very promising biomarker is plasma p-tau, and that could be either p-tau 181 or p-tau 217. Again, very good correlation with the PET as well as the CSF biomarkers in terms of detecting both amyloid and tau pathology. However, at this point, I think that eventually the future will be to have blood biomarkers, but at this point, I feel that there is more work that needs to be done to establish the diagnostic cutoff that can be used clinically as well to make sure that we are looking at diverse cohorts, so the widespread applicability of these biomarkers.
Dr. Algeciras, thank you very much for that very, very good presentation on these CSF biomarkers. There's a lot of richness there, and we've seen a lot of questions coming across. We'll do our best to discuss those. But now, as a final section, I'm going to come back to Dr. Hu, who's going to discuss the potential upcoming paradigm shift for increased AD testing. Dr. Hu.
Thank you. Thank you, Bob. And then so as discussed so far, really the key transition from how Alzheimer's disease used to be diagnosed to Alzheimer's disease is being diagnosed now is a transition from a function-based to a biomarker-based type of evaluation. So instead of addressing whether someone has sufficient impairment to cause functional decline, we're determining whether there is a presence of amyloid and or tau pathology. In terms of accuracy of diagnosis, whereas it used to be a diagnosis of exclusion, that if somebody will be diagnosed with Alzheimer's disease without thyroid abnormality, without B12 deficiency, now there is a confirmation of a positive confirmation of the presence of pathology, which is very important on a clinical level. Early diagnosis also allows advanced planning, which has actually been demonstrated in clinical trials to save money and improve person-based outcomes. In terms of and finally, early recognition of specific pathology also allows the opportunity for non-pharmacological means to be implemented, especially if in future clinical trials, some of these means can actually be shown to reverse the biomarker changes. And I think very often people are correlating this to the diagnosis of preclinical cancer or preclinical heart disease to allow the earliest disease modification. And I think that is what we're hoping that this field will move towards, rather than just recognition that the disease has spread widely. And as we mentioned earlier in some of the clinical trial-related topics, again, biomarkers are increasingly used in the design as well as interpretation of clinical trials, especially if they are amyloid and tau targeting trials. First, by including amyloid and tau markers in enrollment or inclusion, you can reduce the sample size so that you don't have to account for the 20-30% diagnostic inaccuracy Les spoke of earlier. And it will also facilitate faster referral for patients with diagnosis and biomarker diagnosis to enrolling studies. Very often in the past, when biomarker-based analysis was not widely available, the patients with MCI and mild Alzheimer's disease would need to enroll into a study, go to a screening visit before finding out whether they have Alzheimer's disease or not. Depending on the trial, that information may or may not be shared with the participants. Nowadays, if this is available, the patients can know ahead of time and they can make their informed choices as to whether to approach one or another study. Importantly, as I mentioned earlier, the non-pharmacological disease-modifying approaches can potentially result in biomarker changes. And here's some of the studies, 2 studies in the U.S. and 1 study from the U.K. that it showed that an unhealthy lifestyle can increase someone's chances of developing dementia. And currently, the large-scale multinational finger trials are reporting multiple factors to reduce the risk of Alzheimer's disease, including regular exercise, healthy diet, mentally stimulating activities, reduction in cardiovascular risk, and improved sleep. And very often, as is the case, the biomarkers, even in absence of a pharmacological disease-modifying therapy, may be a wake-up call for people to recognize that the earliest pathology has already set in, and the need for improving lifestyle becomes many-fold than without biomarker availability. So now I think we want to talk a little, kind of walk through 2 potential cases as how the future of clinical diagnosis, and I think in some centers we're already doing this, can transform from the pencil and paper testing base to a more biomarker-based type of process. So let me present the first case. And this is a 65-year-old male college professor. And over the past year, he has struggled to find the right words while lecturing. He is going through a divorce and under significant stress, so he wonders whether some of the changes he's noticed could be due to stress. He also has several books he's reading, and several books he's writing, and his language ability in terms of finding the words and the writing eloquently do not appear to be what they used to be. As a healthy college professor often is the case, he does not take any medications except over-the-counter vitamins and a host of supplements. An MRI shows subtle shrinkage of the language area, and when on a bedside screening cognitive assessment, he scored 24 out of 30 points, putting him at the cusp of mild cognitive impairment and mild dementia. He agreed to undergo lumbar puncture for CSF biomarkers, and we sent the CSF biomarkers for analysis, and I'll let Dr. Algeciras discuss this part.
Yeah, so when we look at the CSF biomarkers, you can see that A beta 42, A beta 40 were tested as well as total and phosphorylated tau. A beta 42 had a result on what is considered on the normal range, but when you use the beta 40-40 ratio to normalize for potential changes in differences in production of amyloid, now this ratio is consistent with AD. Both the total tau, the p-tau, as well as the total tau and A beta 42 or p-tau and beta 42 ratio are all also consistent with AD.
So whereas in the past that one might have recommended, whereas in the past, one might have recommended that we reduce the stress, maybe cut back on work and start an antidepressant to see if his memory and word language use would improve with a biomarker study. And in the setting of this impaired MMSE score, the patient was started on the conventional symptomatic medications. And then the patient also decided to enter a clinical trial for novel immunotherapy targeting Alzheimer's pathology. And I think this last point really drives and really emphasizes the importance of biomarkers, where the person now has a choice in terms of whether to do this or not. Second case is a 75-year-old woman who has hypertension and type 2 diabetes, both risk factors for Alzheimer's disease. Over the past year, she may have experienced some mild memory loss. She herself is not particularly concerned, but her daughter is, and this is another common scenario. She got lost one time on the freeway driving home from a friend's house, just one time, and she at times takes Benadryl at night to help her fall asleep. She has a remote smoking history, and her MMSE is 28 out of 30. Her MRI is mostly normal, but there are some minor changes suggestive of cerebral vascular disease. She also agreed to undergo a lumbar puncture for spinal fluid analysis. So is the question for us when we're addressing in the biomarker, is this normal aging? Is this MCI Alzheimer's disease? Could this be vascular cognitive impairment? Dr. Algeciras?
Yes. So when we look at the biomarkers for this individual, you can see that the A beta 42 was low, but when we do the normalization by using the A beta 42 to A beta 40 ratio, this was a normal result. Similarly, both tau and p-tau were within the normal range, as well as the p-tau or t-tau A beta 42 ratio. So from the biochemical perspective, these results were not consistent with AD. So Dr. Hu, will you comment on recommendations for this patient?
Sure. In somebody like this, what I would generally say is that there's currently no evidence that the patient has Alzheimer's disease. So given what we know, this is likely a combination of normal aging plus a little bit of the factors for the effects of cerebral vascular disease, however mild it may be, that's visible on MRI. In general, I would still recommend healthy lifestyle because that it is not harmful. At the same time, I also emphasize to the patient and her family that it doesn't mean that she won't develop another disease in the future, but certainly currently, given her normal spinal fluid findings, I do not anticipate her having progressive cognitive decline over the next 5 to 10 years.
Dr. Hu and Dr. Algeciras, thank you very much for those good illustrations in case studies of the CSF markers and what they mean and can mean and how you'd interpret those. We do have a few minutes left, and I'd like to go right to a few questions if I could. And the first one I'm going to direct to Dr. Shaw. Dr. Shaw, in your presentation, you showed us a table which was allowing you to do comparison studies of CSF samples and results versus amyloid PET. Could you just comment about the validation that was used for the PET and autopsy standards against which you used the test as surrogates?
Yeah, so as Dr. Hu had mentioned, there are 3 FDA-approved ligands for amyloid PET, and 3 companies sponsoring each of these individual ones, PET scanning. And in each case, and this was really required by the FDA when they were doing the validation, they had to compare to autopsy-based diagnosis. And so the companies involved had to arrange for this, which is not an easy thing to do when you're dealing with living people who then pass away with this disease. But nevertheless, they did. And in each case, they had very high degrees of sensitivity and specificity, and thereby rendering in the scientific community these as surrogates, at least validated surrogates for Alzheimer's disease pathology, for amyloid plaque burden pathology, in the specific case of amyloid PET. And so when the studies that are summarized in the PowerPoint that you're referring to are done, they're not redoing the sensitivity and specificity of the imaging test. What they are doing is using those tests as the surrogate for autopsy and then making the comparison with the CSF testing. And most of these studies that are summarized therein, not all, but many of them are done with the newer automated methodologies. That is the Fuji-Rebia Lumipulse, of course, but also the Roche Alexis, a highly automated system. So that the fact that those were the new guys on the block was driving those companies to do the very best they could for validation, and that was amyloid PET comparisons. That's kind of the background to that. I hope that's helpful.
Thank you very much. Our next question is for Dr. Algeciras, and it's a specimen-related question, which we always like to be able to get in. And it's as follows: do CSF samples get affected in a syringe pull versus a drip sample?
Yes, great question. And that is addressed very nicely on the guideline document that I mentioned. You do have the potential to lose some of the analyte in the syringe, so that's why the drip method is recommended, or the preferred method for collection for AD biomarkers.
Thank you very much. Now we have an important question about blood-based biomarker panels and their clinical performance. There's an enormous amount of initiatives both in the diagnostics industry and among pure scientific researchers on this question, and there's lots of things going on, but I'm going to ask Dr. Hu to address this question of the blood-based biomarker panels. In your current clinical practice, what do you make of that?
Sure. Thank you, Bob. And I certainly agree that there's a bit of enthusiasm for a blood-based biomarker. At the same time, blood is not an easy fluid to work with in routine clinical settings. I'm speaking of this as someone who standardized blood collection at 2 Alzheimer's centers, and I do not take that up as a hobby. It is certainly a very prolonged process, especially if there's personnel turnover and the need for additional materials in the setting of, something like COVID-related tube shortages. And for now, I think based on the available research, the blood biomarkers are more correlational than predictive at the individual level. So it is potentially beneficial as a screening tool for clinical trials. But when we are faced with patients who want to know the difference between 80% accurate and 95% accurate, we prefer to use the more accurate test of them all, which in this case would be the spinal fluid over blood. In addition, I think that there are other neurodegenerative diseases as well as neurodegenerative mechanisms such as inflammation, which are not detectable in the blood. So until we have a fair representation of some of these others, which are near maturity in the CSF, I think from a clinical perspective, we're still picking CSF as a preferred method.
Thank you very much. Dr. Algeciras, I'm going to come to you next with the following question, and a quite interesting one. Are there reference values of the A-beta 42, A-beta 40 ratio to determine Alzheimer's disease in different populations?
So right now, the cutoffs that are available are there are not population specific. So if we're talking about different cutoffs for African Americans versus Hispanics versus Caucasians, we haven't developed those yet. We only use one cutoff is being used. It is something that is being looked at as to whether the use of different cutoff will be relevant in different populations.
Thank you. And Dr. Shah, would you care to comment on that same question? Reference values for different populations?
No, I agree with Dr. Algeciras, and she very appropriately made note of differing ethnicities or other socioeconomic circumstances. There's a multiplicity of factors that we believe there's scientific evidence at an early stage of developing that evidence for possibly some differences in the biomarkers, but it's way early, and we do need those studies that Dr. Algeciras has referred to. I can assure you that in the Alzheimer's disease world, there's a great deal of interest in this question. It's very important because we want to make sure that what we're doing is really representative of the population that we live in. And that means we have to be as absolutely inclusive of all sorts of different ethnicity aspects, socioeconomic, and the like, and be very mindful of that, as many of the investigators involved are. But it's going to take large numbers of study subjects to really pin this down. But what I can say is the National Institute on Aging has made a major commitment to this topic and is funding all sorts of studies, including in the ADNI study, for example. We now have a new core that is devoted to diversity, and we have the leaders of the core, an African American and a Latinx, are doing a wonderful job of making sure that at the tail end of the ADNI 3 study and in the ADNI 4 study coming up, that we really are more inclusive, and it costs money. The reality is it takes a lot of investment of resources to do this, but I know a growing number of medical centers, I'm sure at the Mayo, I'm sure in Williams and at ours at Penn, a great deal of mindfulness about this topic. So great topic to bring up, but we're at an early stage and we need a lot more systematically collected data.
Thank you, Dr. Shah, and I will second that. That's excellent, good news, and we see that on many fronts right now in laboratory medicine. All good. I'm going to ask Dr. Hu for a very brief answer because we do have some time constraints now, but I'd like to ask you, Dr. Hu, do you have any information on what the biochemical results would be in the differential diagnosis of someone with FTD versus AD?
Thank you, Bob, and thank you for the question. And as we know, when we come to the etiologic diagnosis, FTD is a clinical syndrome, not a pathology. So we're really talking about FTLD-tau versus FTLD-TDP. In our experience, which is now being validated in 4 separate studies, if the person does not have Alzheimer's type of biomarker profile in the spinal fluid, and there is a reduced phospho-to-total tau ratio, then it's highly indicative of TDP-43 pathology. So in clinical practice, and we generally would use this type of models. And the first question, is it Alzheimer's disease? If it's not, and then the clinical symptoms are fitting with potentially a frontal lobe or a language-based syndrome, is there sufficient evidence to suggest it's an FTLD? If it is, then we often go along with that assumption. If it is not, then the presumed etiology will be tau or alpha-synucleinopathy. Now, there are some caveats in terms of rare disorders, familial disorders, but certainly from a general practice perspective, that's where we're headed towards.
Thank you. And let me ask you then, Dr. Hu, for a very final brief comment on virtual grand rounds.
Yes, and I think that, as we're discussing, as we're finding out today, and as some of the cases illustrate, there are interesting cases, there are interesting discussions that warrant further attention. And so I think the goal is for a community such as this to have future opportunities to get together, talk about interesting cases, to talk about interpretations and technical challenges. And then I think this would really advance the field beyond just those of us who do it every day. We can then better understand how this can be applied more broadly in the community and in the laboratory settings across the country.
Thank you. Thank you. And with that, I will give you the last word and begin to wrap up. I would like to thank Dr. Alicia Algeciras-Schimnich, Dr. William Hu, who you've just heard, and of course, Dr. Leslie Shaw. All 3 speakers did a magnificent job. I do want to also underline my thanks and appreciation to Fuji Radio for their sponsorship of this important program. And in addition to that, I want to thank all of you. We've had an enormous audience today, and I'm very grateful for that. I'm very humbled for you to take time out of your very, very busy schedules to attend our webinars, and this one, of course, of such great importance. So with that, thanks once again, Dr. Algeciras, Dr. Hu, Dr. Shaw, Fuji Radio, and all of you. And with that, I'll bring today's webinar to a close.